I see this moving forward in the sense that we have to prove clinical utility of these assays, in the sense that when you order an assay, that the results of that assay are going to inform the doctor or the physician to make a decision. When you want to make a decision, you want to have an assay that helps inform the patient and the provider. With these MRD assays, there really is only going to be two things that are going to happen when you get a result. It's going to be either positive or it's going to be negative. If it's positive, are you going to do something about it? Are you going to change therapy? Are you going to start therapy? Are you going to intensify therapy? On the other hand, if somebody has a negative, especially with these ultrasensitive assays, because they're so sensitive and they're already negative, right? That means that there's nothing, right? So do you really want to continue therapy on this patient? Or maybe there's space for de-escalation, and we have to prove this through clinical trials. We have a de-escalation trial that MD Anderson's called the molecular PCR study. I do feel like the de-escalation trials are going to be more quicker to show results. Also, we need the FDA to help guide us into what the future looks like in terms of, for example, can we use clearance of ctDNA as a marker or as a surrogate marker to even approve drugs, for example, right? That's what happened with PAT-CR, right? I think the ultimate goal is that all decisions made in oncology will be somehow guided by ctDNA. But I think as a field, you can't just put it all into one. I think there's going to be parts of it that will start having indications quicker than other parts of it.
So you're saying surrogate endpoints is probably the first thing.
Yeah.
De-escalation is the next thing. It's a great time to be in the field.
This is where you were supposed to be.